Thank you. When I was reading the topic, mainstreaming affordable medicines, affordable telemedicine solutions, experiences and learning. I am fortunately or unfortunately wearing two hats. And there is a small third hat also. One is I was an ENT surgeon for 14 years. Then somehow decided to change the profession, went to law school and became a lawyer 20 years ago. So I'm a pharma healthcare lawyer, and while we were sitting a few years ago, I realized that at that time 135 was in pipeline and thought something is really going to happen in social sector, quote unquote. And our founder Nishith Desai told me, Milind, you are a doctor, you have done a lot of work in Rotary, Lions, JCs, and almost 80% of the work happens in healthcare. And more work is going to happen in healthcare and some education. I belong to an educational township called Vallabh Vidyanagar, born and brought up there. So he made me think, why don't you lead the social sector practice also? That is my third hat. And wanted to develop something, so picked up one very smart lawyer who did his post-graduation from Tata Institute of Social Science, Rahul Rishi, and developed this practice. But coming back to topic here, when you talk of affordable healthcare, India is a challenge, honestly speaking. When you talk of telemedicine, even further challenge, because it's a new animal on the round. And mainstreaming them becomes a huge challenge. I'm so happy we have excellent crowd here. So before we move on to the discussion, and we have a wonderful panel here, not going to be a panel, it's going to be more of a fireside chat. The third panelist could not be here because of medical emergency. And how telemedicine evolved, and I was talking to a few of my doctor friends in Gujarat, and one person said, I am enjoying. Second doctor said, I don't care for it. So this is a situation, So, before we start, one small story comes to my mind suddenly while walking here. There was a very small bird flying in a very cold climate, very cold, chilling, and keeps on flying and suddenly gets tired and falls on the ground. And because of very cold weather, starts gasping and almost dead. Then one cow was coming, looking for something, and drops cow dung on the gasping bird. Now the warmth of that cow dung gives life to that bird, and bird starts thawing and gets excited, starts singing. A hungry cat was moving around looking for something to eat, and was like, suddenly hears singing bird sound. Where is it? I am hungry. Finds out it's coming from the cow dung, removes the cow dung, finds the bird, catches the bird, eats it away. This is something comes to my mind when we talk of telemedicine, making it affordable. That's why. What three messages come from this story? One is, not anybody who drops shit on you is your enemy. He can be your friend. Second message, anybody who gets you out of the shit is not always your friend, can be your enemy. And the third most important, that is where so many doctors are, when you are in a dipshit, keep your mouth shut and start thinking how to move it. This is what I think is happening in a telemedicine platform today. You have doctors, you have platform providers, you have patients, you have people like you who are providing platform, who are doing some meaningful work in this space. But you need patients, you need doctors, ultimately, end of the day. And when you talk, and I'm happy that affordable telemedicine is the topic, that if you see today, first of all, healthcare in India is, how many of you are doctors here? Any doctor? One. Okay. Healthcare is very fragmented. And I have been doing deals of private equity as well as acquisitions. There is tier 1, there is a elite tier 1, tier 2, tier 3, tier 4B and extreme rural. This is how telemedicine, healthcare is there. But if you see, I always call it a tripod. One is affordability, second is accessibility, and third is safety. And on this tripod sits a beautiful camera, which is a patient. Whatever we see here is patient-centric in India, and it should be patient-centric. That is why we have to make it affordable. And today, the greatest challenge what we are seeing is how to make healthcare or a facility available to a patient, be it in a remote area, be it in a rural area, urban area. Let's not go into that. Slowly we will move on to that. That is where I think the telemedicine really came big way, and I firmly believe that a lot of people say that COVID was a havoc. It was a havoc, but pandemic was a crisis, but brought some amazing opportunities for the betterment of people. Telemedicine came out of that. I am remembering before COVID, for many years, even today, there is no law in India which governs telemedicine. There was a time pre-COVID that a doctor sitting in Mumbai cannot consult a patient sitting in Delhi over telemedicine platform on a phone or a web. Zoom boom तो अभी आया, पहले कुछ नहीं था लेकिन नहीं था, something like that. Why? Because Medical Council of India did not allow that. Now, I very aggressively spoke in one of the telemedicine conference where Dr. Paul was around. That time has come that you have to give telemedicine practice license, which is nationally acceptable. It was a huge problem, and that's why it was not flying off. And then came COVID and telemedicine practice guideline came. And I'm so happy that we are one of the important people who have drafted that guideline, which is a dynamic document. So, if you see this accessibility, as I said, is a very important point. And when you want to make it affordable, accessible through telemedicine across country. So do you think when you talk of accessibility, let's not touch affordability part at the moment. So many gaps are there, according to me. You have to connect the dots so that proper healthcare is accessible. So do you think telemedicine is a solution? Partha, your view.
Sure.
Let's have a short answer so that we can talk more.
Right. See, the thing is that since for the past 2 decades, India has made rapid strides, in every sector, even in healthcare. The doctor to patient ratio, population ratio was very high. It came down significantly, but still, it's around 1200 to 1, and even the population to nurse ratio is even worse, like 600 to 1. So the basic thing is that, of course, it's a big challenge, especially in the remote corners of the country, because that is where the real need is. No doctor wants to be posted there, wants to work there. So we see a big challenge in the healthcare. Now coming to telemedicine, I think it provides that solution to the gap in terms of, first of all, I would say remoteness I was talking about, because the rural area faces such problem. So it gives one of the mediums through which a villager can directly consult a doctor, close to his residence. So accessibility and remoteness is one. Number 2 is specialist, accessibility specialist doctors. So when even basic doctors are not available in the PHC, so obviously we don't expect availability of specialist doctors. But again, through telemedicine, one can get access to a specialist doctor, consult the doctor, and find out even the seriousness. Like if the ailment is very serious, then the person is to go to the, of course, telemedicine is not a solution for everything, but then at least it provides the first care solution. So second is specialization. Third one is I would say quick care, because there are situations when we face emergency, and especially in the rural corners of the country, it will take some time to reach even to the nearest doctor or the nearest hospital. So even for that, even immediate thing needs to be done, can be done through telemedicine. Then the other point was that in affordability. So telemedicine have significantly reduced the cost for both, even for the health providers also, and also for the patient, even for the government, right? And another very important aspect is health education. Preventive healthcare, which is really one area which is neglected in India. So health education can also be done through telemedicine, which is an upcoming area, and I'm sure in the coming days it will be addressed. So yes.
Sunil, your thought. Would telemedicine bridge this gap?
So, thanks Dr. Milind. I represent ACG, and many of you who don't know our company. We are integrated capsule manufacturing. We are Indian multinational company, and last year, talking about the scale of the company, last year we manufactured 140 billion capsules. So that means at least 20 capsules for every human being on this planet. So we are the second largest in the world. Talking particular point, and you mentioned very nicely, Dr. Milind, about affordability and accessibility. So let's see accessibility first. So it's purely about the doctor and patient when we're talking about the health. And WHO categorically mentioned that in general the ratio should be 1:1000. So for every 1000 people, one doctor should be there, so that accessibility can be ensured. But India's figure is very dismal. It's around 1500 to 2000 on an average. And when we are talking about a rural area where most of us do work or getting connected with the community, this question is as high as 25,000. So with that ratio, 25,000 people depending on one doctor, you can understand the kind of accessibility they are having. And then there are, as Parthasarathi, there are a lot of infrastructure and behavioral challenges people are having to get those services to make their health better. So the whole ecosystem needs to look from basic point of view. So if we are talking about accessibility.
Yeah, I think that's very important. So Partha, you mentioned about the need for telemedicine. I'm sure you are also involved in very interesting projects on telehealth. Let us broaden it. And pandemic is one of the reasons why it is really flying off, honestly speaking, and many doctors call it topping on the pizza for them, that I keep on seeing patients but शाम को 4 से 6 बजे extra कर लेता हूँ. This is a fact. So can you just share how telemedicine evolved during pandemic and after pandemic? Do you see the same growth, or there is a quantum jump after COVID? Of course, COVID is not going to die down, right, but it has reduced.
See, when telemedicine was initially launched way back in 2001, ISRO did it with Apollo hospitals. So if you see, like, it took almost 20 years, to accept it, adapt to it. And if COVID wouldn't have come, probably we would have never adapted it. We could have, even government would have never thought of a solution, that, it can reach to the remotest locations. So first and most important point is, it helped us to adapt the technology, to accept it, because, as Indians, we don't feel comfortable unless until a physical person is sitting in front of us, touching my nerves and putting a stethoscope. So even like if educated people like us feel the same, obviously we can understand the villagers' point of view, so in terms of acceptability, it was very less, because as an organization, we ourselves had run telemedicine programs since 2018. So 2018, and we were running programs in Bhind district of Madhya Pradesh and Bangalore rural district in Karnataka, and both the locations we saw the acceptability was very really low. But then suddenly 2020 COVID came, and even all of us were struggling to get access to a doctor. Of course you can understand what have been the situation of blue collar workers or villagers, and that is when suddenly there was a because they didn't have an option, suddenly they adapted the technology, they accepted the technology, and then we suddenly saw a huge spike in terms of telemedicine rise in India. So whether it is urban areas or rural areas, and we can see now even government have launched e-Sanjeevani project, and I think August it touched 14,000 crore consultation. That's a huge number. And then there was, so if we go forward, if you see, there have been constant evolution of technology due to COVID, and that has really helped in terms of platforms where consultations are taking place, in terms of technology, in terms of even we all remember there was a huge shortage of oxygen plants, and then become government invested. So they also invested in technology. I remember in 2021, we had gone to, made the CMHO of Bhind district, and he said that, and I was not very sure how will he react about telemedicine, because, we wanted to have a public-private partnership. And I was surprised that, he was elated about it. He said, yes, I want to do it. We have one unit in our district hospital, but it is non-functional. So we need to know how we do it. And then, I would say, as you rightly mentioned, there was also no regulations, no rules. So Medical Council of India, when it took out in March 2020, the detailed guideline, and that changed the game. So doctors also feel comfortable with it.
True. He touched upon very important point how it got evolved during and post pandemic, and we are talking about providing and mainstreaming affordable telemedicine, and that's where the rural area comes into picture. So if you really want to do SWOT analysis, I don't want to go into strength and weaknesses, let's park that. But of course the COVID, forget about COVID also, I think, I don't like to use that word, but today telemedicine has brought a lot of opportunities for rural area primarily, for doctors, for patients. In fact, the patient somewhere down can easily talk to a doctor, sharing information. I don't want to go into data privacy, etc. that we will discuss at the end, which has become a huge challenge now. So I just want you to share from your experiences. Is it really an opportunity? And what are the challenges which players are likely to face or are facing, and how you navigated through them?
It's very important and interesting point, and because we work with the rural community, so we have seen those challenges from very close. So before coming to actual challenges, let me share one survey outcome. Indian Institute of Public Opinion did conducted some survey to understand the issues faced by the rural people in getting access to health, and they come up with a surprising figure that around 87% people in rural area have to travel 8 kilometers to get basic health services. I'm talking about basic health services. So, and this survey, when we are saying that getting access to better health, basic health services, who are the participants of these surveys? We need to think about. We are talking about the rural area. Not everyone is very vocal to talk about that they are interested in seeking the health-seeking behavior. I come across an interesting story. I was in one of our projects near Pune, in Maharashtra. So we were having some mobile health unit project there, and I traveled to one of the villages. One elder people came there. Every day he comes to the mobile health unit and just take painkiller and just vanishes from there. So on that day also he came. He has taken medicine and just started heading back. I stopped him, asked, what challenges you are facing, what are the issues you are facing. He said that no, I have some pain in my stomach, and that's why I am taking painkiller, and that's fine. So then doctor intervened. So he said that he is having actually some tumor kind of structure in his stomach. But in spite of repeated persuasions, he is not sharing with his family, and he is not going further diagnosis. So his words were very touchy. The old age people told me that I cannot tell this to my son. I can expect only 2 square meals from my son at this age. So I cannot expect anything beyond food. So this is a very sad story in rural area, particularly the age-old people and the women. They are the last person who will talk about their health issues to the family, and this is the awareness we are saying, the health awareness and the health seeking behavior. So definitely these people have not participated in that survey where it is 7% people said that they are traveling 8 kilometers. So that number is actually so high we cannot imagine. So I'm talking about the challenges. So one is key challenge, the mindset and the awareness among the people, how to get aware about their own health, to get better services there. And then definitely there are not infrastructure challenges. There are the villages where we do not have mobile network available as on date. Forget about the internet accessibility. So we do not have, there is hardly any primary health care or any doctor visiting in those centers, those villages. So they are totally dependent on the quacks and the local practices, age-old practices to tackle their health challenges. So if I summarize on challenging part, definitely there is lack of awareness, lack of reaching out to people, change their behavior. Then infrastructure part, lot of investment required. So somebody yesterday in inaugural session said that health is on the top priority on CSR spend. Yeah, there are reasons why health is on top priority. It's not that we did enough in health. We are still lagging so behind. With 2% of our GDP spend, what changes you can expect? We personally observed in our houses that around 8 to 10% of our income we are spending on nominal health issues. Forget about the critical health issues. And country as a country we are spending 2%, and we are talking that we did enough in health. Why need to spend more? So there is a lot of requirement to develop the infrastructure in rural area to broad changes so that people have access. They reach to awareness. There are a lot of opportunities also. It's not all the side figures. Now, because of the technology and thanks to your participation to create the paradigm shift. Now in 2020 we have certain guidelines regarding telemedicine. So now it's time when we are talking about AI. That ratio, that skilled ratio 1 is to 25,000 still is in my mind. So the only way that we need to create some channels like AI so that lot of burden from doctor soldiers can be removed. And some basic diagnostic or basic symptom wise analysis can be done through using AI. And the patient history or data security is a challenge in like 2019. So a lot of technology has come, like blockchain is we are using in elections, we are using in COVID. So the blockchain technology is a huge impetus to our sector. If we are adopting such technology, definitely these technological challenges can be resolved.
Yeah. So, a very important point. Along with that, did you find challenge to have the other side? Hospitals getting involved in this platform. I'm talking about rural side now. Urban is possible. Or finding a doctor who can render his or her services. Was that a challenge anytime?
It is challenge. So as I said, before switching over to telemedicine, we were having this mobile health net. And we tried to get a female doctor because we want to cater the female patients in the room.
Okay.
And every next month we have to change the doctor because there are a lot of opportunities available in the urban area. So doctors, although there are some limitations, they hardly prefer to stay in rural area. That is the fact. Most of the good doctors try to switch over to urban area. A lot of things are socio-economic things are there before why they are moving to this urban area. But there is challenge to availability of doctors. In government hospital, in multiple super specialty hospitals also, I'm talking about the Dahanu. Dahanu is a place, who don't know, this is a place which is around 60-70 kilometers from the national financial capital, Mumbai. And it's well connected through local train and the highway. But I'll tell you, this is again most neglected, just close to Mumbai. Where people for any secondary level of treatment, they have to travel to Mumbai. There is no doctor.
True.
So that's the fact.
Yeah. So another important challenge I see, which the entire telemedicine, forget about AR, VR, machine learning and all those things, because technology always comes with a baggage. Never forget that. There's going to be a huge problem. But the biggest challenge, and I'm sure is going to become a huge concern for all telemedicine service providers, be it a platform providers or not-for-profits involved with either hospitals or corporates or some rural area, is the new Data Privacy Act. It's the most dangerous thing that has happened. Is it recorded? It is recorded. So I have to. So the point is, there is no specific healthcare data carved out in the data privacy law. Earlier there was DISHA, which was digital information. I drafted that law. I signed off on the bill, which went for comments. So they have removed critical data, health data from the definitions. It is all personal information. So any information being shared cannot be shared with third party in electronic form without informed written consent. And telemedicine, there is a plethora of movement. Even going on WhatsApp. See, होता है वो होता है. India में you can buy any medication from chemist shop, but technically it is not allowed. But this data privacy law is going to be a challenge. The reason, of course, we are waiting for rules and lot of representation has been made from healthcare. I, along with Dr. Rajendra Gupta and the DCG, are working very actively on carving out healthcare data law for people like you and others. Is unless there is a consent, it will become a non-compliance. And the Data Privacy Act, which just came in August, September, has a provision of penalty up to 250 crores for the data fiduciary. Now, data fiduciary is defined person who collects data. So, anybody who is involved in telemedicine platform in some form, you collect the data but remain a marketplace like a traffic police. Yahan se li, yahan diya. But liya or diya is a process. So, there is going to be a huge challenge. Something needs to be there. So, that takes me to next important question, very short and brief. Is various models are there, telemedicine. Model in urban setup and model in setup. I have seen personally, help few clients also, are very different, poles apart. And when you're talking about mainstreaming them and making them affordable, can you quickly share both of you on how models are developing or have developed quickly on rural area and urban area?
So, I think, we are talking about evolution of telemedicine, and that is where also the, telemedicine has helped, in telehealth and generic health of the villages. So, a few things especially really helpful and which is being now addressed. So, for example, as the country is progressing and, socioeconomic, the conditions of the people are also changing. So, there is certainly we are seeing a very high rise in non-communicational diseases, NCDs. Like, almost now in 2019, it was found that 67% of the people of the country have died due to NCDs, and especially about cardiovascular diseases. So, these type of things can be largely be addressed by, a thing like telemedicine, right? We need to do awareness, we need to do concentrate on this. And then another problem, and which is now being addressed, is availability of radiologists. It's shocking that in a country like India has only 10,000 radiologists over a billion population, and only 10,000. So you can well imagine when doctors are ready to stay in rural areas, how a radiologist will stay. So but then this can be addressed, and it's already being done, through teleradiology. So there have been very interesting models, and in fact, government of Uttar Pradesh have appointed Apello to run telemedicine, teleradiology in 113 CHCs in Uttar Pradesh. So this is a very important thing that is coming up, and not only about doctor getting access to doctor, but then getting access of diagnostic services. So that is also again something that is moving ahead. And another important aspect of telemedicine, apart from the regular diagnostic things, is talking about mental health. Because mental health, so now nowadays people are started speaking about mental health. A few days back, it was like almost related to madness, right? But then these thing, mental health is not something that talked about only in urban areas. So in rural areas, this is a big issue, but then people are not speaking about it. But then again, with telemedicine, not only apart from the doctors, but psychologists also getting access to the villages, and they are talking about mental health. So these are the few models which I have seen really evolving and going to help in future.
Your view? Any models?
Yeah, so Dr. Milind, now government is coming in big way. Like ISRO has connected with many of the villages.
Bangalore,
to,
yes.
Villages to the multi-specialty hospital. So that's the one model which is from top level. It's going on, but what we understand and experience, we have used a hybrid kind of model. So where we have a physical presence of through mobile units and through doctors visiting to the villages, but we over the time we realize that we cannot continue to spend over year after year on such a model. So somewhere we need to take a pause to think about how we can reduce the cost of cultivation, because we need to reach out to the next level of communities around. So then we thought, why we should not try the good telemedicine. So what I understand in my basic understanding on telemedicine, there are three key segments of telemedicine. One is teleconsulting, and the second is e-dispensing, and third is remotely monitoring the patient status. So we understand that e-consulting or teleconsulting is a quite easy thing we can do, because we had connect with the community in those areas. We could create awareness that you can use some technology where they have access to basic internet and mobile network, so they can use this e-consulting or teleconsulting mode, so the doctor need not to visit on regular basis and every day into those villages. Later on, then we have set up, when issue was where from where they should get medicines, because then we have to travel 8-9 kilometers to get medicines. So then we have set up some kiosk in those panchayat houses, where based on the recommendation the doctor is giving some code, and using that code they are getting medicines from that kiosk. So these two things we could establish and we could experience. This is actually helping us to reduce the cost of implementation over the years. And now we are thinking how we can ensure that we can monitor the patients when they are treated under telemedicine.
So just echoing the Sunil's view, I think which has really helped is a hybrid model. Like we cannot just expect a villagers to call up doctor and
Yes.
take a consultation. So that is not going to happen. So there has to be a mediation between, and that is also we are working. And we also realize that running anything independently is not going to be sustainable for a long time. So and not only us, a lot of corporates in fact are working with various state governments in actually collaborating in e-Sanjeevani. So like we are doing in Bhind district in Madhya Pradesh, we are doing it in Bangalore rural district. Baya Foundation is working in over 14 locations in Madhya Pradesh. And in all this, if you see, so basically there is a trained ANM who is posted in the telemedicine center. She is the one who mediates, enters the data, and because language is also a big issue, right? The doctor is located somewhere in Mumbai, Delhi, or Bangalore. So she helps in coordination, and she ensures that the basic health checkups, the data is collected, her vital stats are checked. So that is something has really worked, and I think and this is where I see CSR can play an active role. So obviously with the limitations of CSR, we cannot take up anything completely, but then we can create good models, and which can be replicated. So government is taking it up, but to always for public private partnership to work, there will be always some issues. So if apart from CSR, if I talk about and I was just having a discussion with one of my friends who are working in telehealth with government, and they say that the margins are very less, it's very difficult to survive. So unless until we are a big player, then of course issues like relativism are there, and the infrastructure, the poor infrastructure still is struggling. We don't have even a 12 electricity in rural India. Many locations are there. So these are the real challenges which needs to be addressed.
Sunil touched upon a very important point that telemedicine is not just teleconsult. In fact, teleradiology you just mentioned started years ago. There was a company in Bangalore. In fact, I remember my friend in Baroda used to remain awake at night because he had a tie-up with one hospital in US, and they used to send wet plate, or those I'm talking about late 90s and early 2000, that at around 1 o'clock when there was an emergency, they will just send wet plate to my friend in Baroda, and he will just report at 1:32 and decision will be taken there. So this is also telemedicine and e-pharmacy, teleconsult, a lot of things. You also mentioned about e-Sanjeevani. So Sanjay Sood is a good friend. In fact, I was talking to him, who is in charge of e-Sanjeevani, about how e-Sanjeevani is really penetrated and is it really affordable. He says affordability is not a problem. Penetration is a challenge. And just to go one step beyond, so Partha, I just want to understand from you quickly, and you are heavily involved in this. Is there a scope to have additional specialized care in telemedicine? Radiology is one, teleconsult is one, e-pharmacy is one. But can we go beyond? Is it possible? Before I move on to corporate and not-for-profit next round and the roundup, but just your views on that.
Yeah, so basically, as I was saying, there are the few specific areas where, telemedicine can play a very important model. And specifically, I would speak about, creating awareness, creating education among the local communities, which is very important. It can be done through it. Radiology we've already covered. And then, I'm talking about mental health. And even now we are talking about maintaining ICUs through telemedicine, right?
Can you elaborate that?
So
Maintaining ICU through telemedicine
yeah.
is a very bold statement.
Right,
So
right, right. So it's a it's a new initiative, which it's still being looked upon, not yet evolved as a process. But then a lot of discussions happening because most of the cases it is about it need to be done through a supervision of a specialist, right? And not always in the CHCs or the PHCs, and because in COVID times we realized that not only in the district hospital but then CHCs should have also ICUs units, right? But then it doesn't have a specialist to monitor them, right? So to remote monitoring, that can be explored, and that is one area which is being explored. The public and government sector both is being explored, and it is something to be seen in the future. So it might work, may not work, but then certainly this needs to be explored.
yeah. Sunil, you talked about you started with a mobile unit, and that's what I remember also. And from there is a journey. Would you mind sharing success stories, your learning and unlearning from your journey from a simple mobile unit to what ECG is doing today in telehealth?
So I would call it success basically it's with reference to a different set of stakeholders. So if we look at as an organization, as a CSR organization, for us it's a success because through introduction of telemedicine in one of the component of our health initiative, we could cater to the next few villages with the similar fund available we have. So that's the one thing. Second, we could make some sustainability point that now this is the setup in this village, and if tomorrow we decided to withdraw from this particular set of villages, this system or the awareness or the facility or services we have created, they will continue with some support. So that's the one way to look at the success. If you look at with the patient's perspective, so I think there is a huge mindset and paradigm shift in the patients, particularly the young generations who are using WhatsApp and a lot of social services. So now they understand that for I'll share a different story. So if someone is getting diagnosed with terminal disease in anyone's family, the first options with the family is to accept it whether it is with the patient or not. And then everyone in the family try to get opinion from different doctors. Practically, it is not possible to take multiple opinions sitting in a rural area. But telemedicine provided the facility that family can get connected with multiple doctors, understand their opinion, what is the course of treatment they can start with. So that's a success, I say. But there are some limitations, of course, because telemedicine up to teleconsulting is success. Now people are understanding that they can consult with the doctor. But when doctor said that you need to go for further diagnosis, you need to go for some laboratory test, then I think they forget the telemedicine. They go with the lab test, getting the report, and then they directly visit to the doctor nearby in that city. So that's physical connect with the doctors. So that is I think not replaceable through telemedicine at all, which we experience. Whatever services or whatever the features we can create in telemedicine, people will always prefer to get physical contact with the doctor, understand and how they can go ahead. But there are uh, there are few cases which we have realized that they can get connected with the doctors, they immediately receive the help or consultancy from the doctor, or they can get treated. So those are the things. There are a number of cases, I can count for a number of cases where they have received immediate attention from the doctor. Second, important point which we could include in our project as a success parameter, we were not treating NCDs in our mobile unit because we understand the hypertension is one of the area where the patient need to monitor for certain period of time if we are providing some medicine. So we cannot do this because our unit is going to that particular village once in a week. So for a week, the doctor is not connecting with the patient. But through telemedicine, now we are including NCDs. So when we are, our doctor is recommending or prescribing some medicines, through telemedicine, we are setting up some kind of monitoring framework. We are checking the status of patient, how the patient is responding to the treatment. And there are few cases when we need to immediately pick up the patient to for further diagnosis of super specialty hospital. So I think that we can present the crucial interventions in the saving somebody's life through telemedicine and getting those kind of solutions in that area.
Yeah. So Parthal come with an opposite question. He talked about his success stories. Do you have any failure stories to share with the audience?
Yeah, so I think, as I was telling, we launched Telemedicine Center way back in 2018.
And how navigated through that failure?
Right. So, so 2018, when we initiated the telemedicine program, as I told you, there was almost zero acceptability. But the people were not ready. The mental block was there primarily. So it required, a lot of creating awareness and, doing. And what we did is actually, we organized health camps, physical health camps. And in these health camps, we introduced them to telemedicine because we realized that, we just call them for telemedicine, it's not going to work. And, we had a lot of failures. So basically, we almost, in a day, we used to have hardly 4 or 5 consultations, right? And obviously, as a corporate, you continuously evaluate a program that how much return you are getting, for the social investment. So we are seeing that, the investment was going very low. So we along with the partners, we have a partner called RSDX Super Specialty Hospital based out of Bangalore, and they are one of the, leaders in radiology also, right? So what together we sat and we understood that, unless and until we make this, this hesitation go, it cannot work. So that is how, we continuously worked on organizing very specialized health camps. In these health camps, we tried to introduce them to telemedicine and make them comfortable about it, right? And when they saw that, he is getting, access to us one doctor physically, and the same doctor say that, you can get access to me as a follow-up in the next consultation. So it made it comfortable. But then again saying that, it's only COVID, which made it possible, otherwise telemedicine would have never been here, Exactly, yeah.
So I think, this is a very important point. I think we all need to understand that failures do happen. And पुराने बहुत statements हमको दिए थे. Failures are important in life. Failures is a precursor. My son, who has a startup, gave me one beautiful line that fail fast. That's what anybody who want to enter into this, fail fast. So we were told opportunity knocks your door once or twice. Chala gaya wo. Opportunity is never going to knock your door. Create an opportunity. And practice makes men perfect. Men includes women also. It's wrong. Perfect practice makes men perfect. You have to work really hard on what you are doing today. So before I move on to questions there, I have a last question, and just on title, that mainstreaming affordable telemedicine solutions, experiences and learning. Before question, any unlearning you want to share? Please don't do this. Want to share? You both are corporates, huh? Yeah. Important people in the entire game. Sunil, he's thinking.
When we say the unlearning, so we normally reach out to the community that whatever we are saying, that people will accept it as a first, as we are saying, because we consider that we are lot of learned people. We understand the subject matter well, but I request you to please go with the open mind, discuss with the community the challenges with sitting with them. So that's the first thing we have need to learn, because we went with the model with the community and we failed. Somebody has broken our vending machines and they have not followed the guidelines we have set in the village. So please sit with the community and learn their challenges in their way and then devise your strategy. So it should be bottom-up approach. So that's the one thing.
Yeah.
I would say it's when we start on any new project, we should take our time, like as you said, fail first, right? So a lot of brainstorming needs to be done before we start any program. So I will just talk about my learnings, our learnings, and so basically we had started one program, similar program, much back in Rajasthan, Barmer district, like, when we started to start a similar program. But then somehow we didn't get, the buy-in from the government doctors and the hospitals, right? So what we did is that we launched a program, started this program, but then, they were, and we wanted to create a PPP model. We wanted to work, and we wanted to work the government doctors. We thought of providing the facility, and the government doctors will actually run it. But then, they were already preoccupied. They were already, there were only 15 doctors catering to a district hospital of 22 million people. So basically, they hardly could give time, and as a result, it failed, right? So I think, we have to give enough time. We get to get buy-in from the government. It is very critical, and it is not only from one official, because they get transferred all the time, and new official will come, right? So get buy-in from the PHC level to the district level, even to the state level, because when you have a state level MOU, it really helps. Otherwise, if you just have a local tie-up, it doesn't work. And then of course support from government, even in terms of medicines, like, so
I'm coming to government part. That's my last question. So, before I have few questions from audience, one last but very important, very pertinent question. PPP, that is how people call it. Let me keep PPP. One is a public-private partnership is one, where government's role has to come here, especially when you are talking about making telemedicine affordable and mainstream it, which is not an easy job. There are so many not-for-profits sitting here. Corporates are important, but I just want to understand from you how government can play a role, and how, because I personally feel non-availability of a skilled people in telemedicine project is a challenge. You don't have people, adequate people. And we are talking to go into rural area, it's a huge challenge. So I just want to understand from you, and a message to them, what not-for-profits can do to achieve this affordable telemedicine and mainstream it, what you can do in that development, in that partnership with them, and then comes the government. Very quickly, 1 minute.
Shall I start?
Yeah, sure.
So, one thing which I observed, that when we are consulting, our doctors are consulting with the patients, so lot of symptoms are misrepresentative, and that's how that leads to misdiagnosis of the disease. And because we are connected through telemedicine, it results in very havoc kind of thing. And because as a non-profit organization, our strength lies in the good connect with the community, rapport with the community. So it's very easy for us to create awareness and create behavioral change in the community compared to the government. Government system, it is almost impossible, which I look into. We can bring change in the thought process of the people. We can train them how to connect, how to communicate the issues, health-related issues through telemedicine. So that's our strength. And the CSR organization, definitely we need to put a lot of investment in behavioral shift, as well as creating infrastructure at rural area, because government always take its time to, and we don't have time to switch the gear towards the telemedicine. So there we can play a vital role to create basic infrastructure in the rural area and create behavioral shift in the community.
yeah, so basically, when we talk about the government attorneys and Sanjeevani, what is happening in reality in many other PHCs I have visited, like, most of the time, the personnel who is running it, they don't know how to operate a system. And due to it, most of the consultation happening just over phone, right? Instead of a video call or video consultation. So I think the most important role for a corporate, even not for profit, is to ensure that the training part of the government officers, because they are just allocated the role, but they not provided the training. So without training, we don't expect suddenly a ANM or ASHA worker to become a tech savvy person. So I think there are various stakeholders in such a project, like like how we run a program, like for this our CSR project, we have a not-for-profit person body who looks after the communities, right? Connect with the communities. Number second, we have a specialized hospital, like who provides the actual telemedicine facility. And third is the government. So I think only one party is not enough, to succeed. So not-for-profit role is to popularize the concept. there are various myths involved in telemedicine. It is equally important to break those myths and then take it forward. Then only, India can truly achieve its goal.
True. Do we have time for questions? One or two questions? Yeah, yeah, please. Mike, please. Just identify yourself. And
Yeah, hello doctor. My name is DPK Babu. I am from Ashraya Akriti, Hyderabad, a non-profit organization. I just wanted to understand what can really help in ENT space, because especially you're an ENT doctor, making ENT health, offering ENT and hearing healthcare to the grassroots
you mean through telemedicine platform?
through telemedicine.
Okay. It's like buying a cloth online from Amazon. There is a guarded risk. Kaisa aega? So, but I totally understand when the telemedicine or telehealth platform definitely has certain limitations when it comes to consultation. And you mentioned ENT. For example, ENT is not ENT, it's a very broad thing. Otolaryngology, ear, nose, throat. On telemedicine platform, it is impossible to examine larynx of a patient. So it would be, so what we can do, what can be done when you are talking about ENT accessibility to remote area, maybe basic consultations and guiding what next can be done. Because when there is a procedural involvement, there has to be a need to go to a nearest doctor. So in fact, I wanted to touch upon that part also, that just providing telemedicine services is not going to solve the problem. Especially when you are doing it in a rural area, please see that telemedicine services which you as a NGO or a corporate along with hospitals or CSCs, now they are called wellness centers, have some on the ground facility where some basic consultation and examination can be carried out. But skin can happen, physician can happen, ophthalmology, no, ENT, no, when there is a specific examination required. But creating this hybrid model, possibly you can reach the remote area. Otherwise, it's going to be very challenging on telemedicine.
Yeah, you may be knowing one of the prominent medical company has come up with video otoscopy, and also
yeah, that is, I'm working with them.
Yeah.
But again, it also would have limitation.
Yeah.
How many you can give?
See,
so
now,
I'm talking broadly. So having some hybrid model along with telemedicine platform, create some physical presence in some form, maybe work with wellness centers or some hospitals in rural area, which will fulfill the purpose of providing healthcare to the rural area.
The technology and hearing
yeah,
healthcare.
AR, VR will help, augmented reality will help, but Jumri Talaiya mein kaise jayega? Any other question? Yeah, Mike, please.
Hi, sir. I'm representing Women Sports Foundation. So my just before the question, I'll just set a context that our community health initiatives, we have to rely on a lot of service providers, doctors, and experts, because it was not our core area, and it was because of the community that we were working with. We identified that it is important to work on the health aspects as well. So my question is that we did explore that we could introduce telemedicine, but we also thought our team didn't have the required capacity or the knowledge. So in terms of non-profits, are there any capacity building initiatives that we can be part of, so that we are probably ready before actually exploring it?
Anyone?
I would like to interpret it in different manner. So think about a complete end-to-end project. So most of the corporate in the present governance or compliance setup, we look for a complete end-to-end project where maybe your 60-70% impetus is to build the capacity. And after the capacity building, what is the outcome you are looking for? So that is important, because now everyone is talking about measuring our impact or what the outcome we are generating through our interventions. So think about a project where your major force is on capacity building and then using those capacity in a constructive manner to get some outcome.
Thank you, sir.
So I think next question you can discuss with them. So just very interesting discussions and deliberations that yes, telemedicine is here, telemedicine is going to grow, but being a lawyer, one advice I would like to give: in whatever form you get involved, don't ignore documentation, especially the liability and indemnity part. You get excited, अरे बहुत बढ़िया काम दे दिया है ECG ने, sign कर दो. Don't do that. Be careful on what you are signing on documentation, because when you are talking with healthcare, a lot of things keep coming in. But it's a great, I personally feel telemedicine is going to be a big boon, becoming better and better. But as I said, there are challenges, there are opportunities, and there's a huge way to end. Suddenly, Robert Frost comes to my mind. I took the road less traveled by, and woods are lovely, dark and deep, miles to go before I sleep. There is a time. Enter into telemedicine. To make it affordable is going to be a challenge, but not impossible. But patience. Warren Buffett very beautifully said, everything takes its own time. You can't have a child in 1 month by making 9 women pregnant. It is going to take 9 months. So patience. A lot of positive things are happening. They both shared excellent success stories. But remember, at the end of the tunnel, always there is a light. It can be of a coming vehicle. So walk carefully on telemedicine path. Thank you.